Keys to treatment of gluteal tendinopathy. All right, so why are we talking about gluteal tendinopathy? So essentially, gluteal tendinopathy is the most common lower limb tendinopathy, affecting up to 23.5% of middle-aged women. That's a lot of folks with tendinopathy. Patients with severe gluteal tendinopathy report low quality of life, equivalent to people with end-stage hip osteoarthritis, as well as similar levels of pain and dysfunction. I think that most physical therapists will say that end-stage osteoarthritis is very problematic, causes a lot of disability, but gluteal tendinopathy pretty much causes the same thing. And gluteal tendinopathy negatively impacts function to such an extent that those affected are less likely to be in full-time employment compared to pain-free individuals and those with hip osteoarthritis. Now, I'm basically a dinosaur at this point. I went to school a while ago. I didn't really learn much about gluteal tendinopathy and how to treat it. Now, obviously, treating gluteal tendinopathy is going to be different than other pathologies. So we just need to make sure we do a good job of diagnosing this appropriately and then subsequently treating it accurately, right? So that's what we're going to do today. To summarize our treatments for today, we're going to be looking at wait and see. Can you wait this thing out? Will it get better over the course of time? What does physical therapy look like? Does it help folks that have gluteal tendinopathy? What does physical therapy consist of? Is it exercise, education? What exactly is it? How about injections? Are corticosteroids effective for gluteal tendinopathy? How about PRP? Is there an effect of shockwave therapy? How about hormone replacement therapy, which is kind of a new treatment for tendon-based issues? And then how about TENEX? This is an interesting procedure called percutaneous ultrasonic tenotomy. We see that a lot at Champion, and it does seem to be pretty dang effective. And lastly, surgery. Is it effective, and when should you consider using it? So first, wait and see. Can we tell our patients to ignore this issue and it'll just go away over the course of time? So Bickett et al. In 2021 followed 24 gluteal tendinopathy patients and 20 control participants over the course of 11 years. And at 11 years, 45% still had symptoms of gluteal tendinopathy, and 35% have developed hip osteoarthritis compared to no participants in the control group, which suggests a possible relationship between gluteal tendinopathy and hip osteoarthritis. So essentially, it seems like if you wait it out for 11 years, maybe half of folks will get rid of pain, which is kind of wild. Plus, it seems like there's some sort of link between hip osteoarthritis and gluteal tendinopathy. What would be interesting to see if you treat gluteal tendinopathy, does that decrease the likelihood to get hip osteoarthritis over the course of time? No idea. Just would be interesting to see that. And then Malloy et al. In 2018 performed a randomized controlled trial looking at exercise as a treatment for gluteal tendinopathy, and their control group was a wait and see group. And 71% of individuals did not recover in the short term, so that was 8 weeks, and almost half, or 48%, did not recover in the longer term, or 1 year. So largely, it seems like if you just wait, some folks might get better. So maybe after about 8 weeks, 30% of those folks do revert to the mean. They feel pretty good. And about half of those folks by the 1 year mark feel pretty dang good. But based on the earlier study, up to around 50% of folks may still have symptoms up to 10 years later. So what I will say is that if things are not getting better pretty rapidly, then they may want to consider performing some sort of physical therapy to get symptoms to go away. And you certainly are going to see folks that have had pain for much longer than 8 weeks. We probably want to try to intervene with these folks just because it might be a long time for the symptoms to go away, and or they may never go away. Hey, here's a crazy stat for you. Gluteal tendinopathy is the most common lower body tendinopathy and affects up to 25% of middle-aged women. That's a lot of tendon pain. And if you're a physical therapist, you're going to have to treat this thing. And well, I got you covered with this evidence-based cheat sheet on gluteal tendinopathy. And here's my promise to you. I'm going to catch you up to date on the latest medical literature on gluteal tendinopathy. We're going to make you an expert. We go over definitions and misconceptions, prevalence and population, natural history. Does this get better over the course of time if we just let it go? Relevant anatomy, pathogenesis and risk factors, clinical presentation, as well as clinical tests, imaging and differential diagnosis, as well as different treatments like exercise, strengthening, physical therapy, injections, extracorporeal shockwave therapy, hormone replacement therapy, TENEX procedure, and surgery. Best of all, this cheat sheet is 100% free. I'll leave a link in the description. Go ahead and click on that, download that cheat sheet, and catch yourself up to date in under 10 minutes. Now, back to your video. So, Kevin, what do you think? Do you tell your patients not to perform physical therapy and just wait it out?
Yeah, I say come back in 1 year, and if you're still having symptoms, we'll intervene then.
Yeah.
No,
I
I
think
think
sometimes you get hit with those revert to the mean police where like we actually don't do anything with our patients. We just like have them wait for a longer period of time and eventually the pain's going to go away. In some cases, I think this is the case, but it seems like for gluteal tendinopathy, not so much. It's pretty stubborn, pretty recalcitrant. A lot of folks are still having pain, at 10 years out. So it makes sense. We probably should intervene with these folks.
yeah, and the link between that and osteoarthritis is interesting and something to keep an eye out in the research in the future, because that would be a good reason to intervene as well, as if you did see intervention reducing the rates of OA down the road, that would be a no brainer. So that's pretty interesting.
Yeah. The other thing I wonder is I know there's a pretty strong correlation between gluteal tendinopathy and FAI, right? And then there's a relationship between FAI, labral pathology, and hip osteoarthritis, right? So I wonder if we're just looking at beat up hips. Like those folks getting more osteoarthritis because they're more beat up and you're just seeing pathology everywhere. So that'd be interesting. I have no idea, but like you said, pretty interesting to see if we could intervene upon that and, improve things over the course of time. So how about education and exercise, basically physical therapy in the treatment of gluteal tendinopathy? And this I thought was interesting because there's only currently 5 randomized controlled trials looking at exercise in gluteal tendinopathy. The first study I think was in 2009, and the second one was in 2018. And then you had 2 big studies in 2018 that we're going to be talking about. And this is potentially one of the reasons why I didn't know anything about gluteal tendinopathy is because there essentially just wasn't any research out there on treating it, right, until 2018 for the most part. So, and essentially, the research is not as robust in gluteal tendinopathy as the rotator cuff, the Achilles, patellar tendon, et cetera, et cetera. I got a really good question. I believe the gentleman's name was Philip, where he wanted to go over what were the best types of exercises for gluteal tendinopathy. And I think currently we just don't have the best research yet, like we do have for other parts of the body. And then my other thought, and we just did a show on the Achilles tendon. We still don't know what the best treatment is for. Even these tendons have been studied for years and years. Hopefully, there'll be more research coming out in the next few years and we'll get a better idea. But dosing is one of those things that we probably need to be more consistent with and figuring out what the best doses is for exercise, both in the frequency, the intensity, as well as the exercise you do choose. We're still all over the place with our prescription, right? But anyway, we're going to go over these few randomized controlled trials and show you exactly what they did so you can use those strategies with your patients. So the first study is from Malor et al. In 2018. Apologize, I'm not saying that accurately, but they had 204 participants between the ages of 35 to 70, and they were skewed more towards that older age, right? Keep in mind that 40 to 6-year-old females are the most common demographic for this type of problem. Their pain had to be greater than a 4 out of 10, and they had to have pain for longer than 3 months to be included in the study. They also needed to have MRI as well as a clinical diagnosis. So they had to go in there with some imaging and make sure they had gluteal tendinopathy. And they also had positive special tests from a clinical standpoint in pain, right? And they had a couple different groups. So they had a wait and see group. So essentially, this group just didn't do anything. They had an education exercise group. So these folks were seen 1 to 2 times a week. They were seen for 8 weeks. And they also had a corticosteroid injection group. So just kind of cool to see if we do nothing, or if we intervene with exercise and education, or if we just give them a cortisone injection, which I think is kind of like the 3 things that these patients are kind of given. So I really like this study. I thought it was just carried out in a very practical fashion. It's going to give us good information about what to do with these patients, right? Can we wait it out? Do we need to do exercise or do you need an injection? So what were the results? The education exercise group, as well as the corticosteroid group, had higher rates of patient-reported global improvement and lower pain intensity at 8 weeks. And then the education exercise group performed better than the corticosteroid group, right? So both of these groups did better than the wait and see. However, the education exercise group outperformed the corticosteroid, which is actually pretty interesting because when you think of corticosteroids, we usually think it's maybe better results in the short term, worse in the long term. This is actually showing the exercise and education group did better in the short term than the corticosteroid, but they both had an improvement. So corticosteroid wasn't ineffective. And at 52-week follow-up, the education exercise group led to better global improvement than the corticosteroid, but there was no difference in pain intensity. So essentially, these results support education exercise as an effective management approach for gluteal tendinopathy, which is good because prior to that, we just didn't really have research or much research to show that exercise is beneficial. And the other piece is that we didn't really know if corticosteroids were going to be a better choice, right? Because obviously, if you can get one injection, gets rid of all of your pain. That's an easier intervention, although it's a little bit more invasive, maybe more expensive than just doing some exercise, right? So I thought that was a pretty good study. Now, I think this is important because when you say exercise and education, I think it's important to know, well, what was the exercise? Which exercise did they use? And then in terms of education, what was the education, right? Like, are we telling patients to push through pain? Are we telling them anatomy? Like, what is important to educate our patients on when they come through the door, right? So in this study, they did a few different things from an education standpoint. So for one, they talked about what is tendinopathy, and they talked a lot about the difference between tendinopathy versus inflammation. And they basically use that as a way to kind of buy in exercise over rest, because I think tendinopathy implies more we need to load it to get it better, whereas inflammation implies we need to rest it or get a corticosteroid injection or take some sort of medication for it to get better, right? They talked a little bit about why you may potentially have this tendinopathy, and essentially talking about overload or overuse. If you do too much, the tendon's not used to it, it gets aggravated, right? The other thing they talked about was that rest is not generally helpful. An active approach is best. And they also promoted people continuing to exercise as much as they can, talking about walking, but talking about walking in more of a graded fashion. So essentially trying to keep your walking on a flat level if you can, and then also making sure you walk for a reasonable time frame, not walking so far that you start to push through a lot of pain. Now, at least in this study, that's just what the education consisted of, right? Also, from a pain perspective, pain of 5 out of 10 or less was allowed as long as you were back to baseline the following day. From an exercise perspective, the exercises were progressive in nature. The patients were given isometrics at first, and they were also given some control exercises. So essentially, pelvic control exercise, making sure you're not dropping into hip adduction or rotation while you're doing things like single-legged bridges. And they're also given strengthening exercises. The isometrics were performed in supine as well as standing, which is kind of interesting. So essentially, you just stand and you widen your feet out and you try to abduct against the floor, right? So essentially, you just have grippy shoes, so your feet don't slide out, and you do a split, and you're just abducting against the resistance of the floor where your feet are stuck to the floor. And they also performed abduction laying on their back with a belt around their legs and just pushing isometrically, right? What are some of the exercises they use? They used a traditional glute bridge. They progressed to an offset glute bridge, which is kind of like a kickstand glute bridge, or one leg is working more than the other. And they progressed to a single leg glute bridge. They performed a regular squat, and they performed a offset squat, and then a single legged squat, making sure you have a neutral hip position while you're doing this. They also performed some functional exercise that more or less resembled a lunge or a step up, as well as some single leg balance exercises. And they also kept a neutral pelvic position. Now, what I will say is think of the demographic that was in the study. So 35 to 70, a lot of folks that are more or less kind of sedentary in nature, probably not used to playing sports. The exercise chosen, I think, were fairly challenging for that population, even though they weren't using a lot of load. But think about taking a 7-year-old and having them do a single-legged squat. It's pretty dang challenging for that population. So in my mind, I think they actually did load these guys fairly well. But if you had, let's say, a 35-year-old runner, I would argue that you're probably underloading these folks with this, protocol. But at the end of the day, we're trying to do our best to try to control for these variables. If we had younger folks do more and older folks do less, and you can make this argument that maybe the older folks got underloaded or the younger folks got underloaded. But that was one interesting thought that I had, just that if you're 35, this probably wouldn't be too much, but if you're 70, ends up being a lot. Any thoughts there before we move on, Kevin?
Yeah, that seems like a really solid study design with those three arms of the study. Because, like you said, those are the three different treatment options we seem to have at our disposal for gluteal tendinopathy. And I know you'll get into some of the other ones, but I mean, that's great to see, is like, as our biases as PTs, that the education and exercise component was the most helpful. And like you said, I think the strength program and education pieces were solid. Again, I agree with you. I think for certain patient populations, we could dose them a little bit more, but I think the general principles are strong. And at least we saw in this study, it led to the best outcomes. So I think that's a good study we can reference with our patients is like, I think waiting for this to go away is probably not your best bet. A steroid injection might be helpful, but we definitely know that the exercise and education piece is the most helpful. So if we can use this study as kind of fuel or ammo to give the patient so they can learn what's going to help them get better. Studies like this are always great. And then I think just the authors on that paper, like if any listeners are very interested in the hip, Allison Grimaldi has so much good research that she's put out. And Bill, I'm going to say his last name.
Vino?
Yeah, he's in. I mean, I feel like they do a lot of their research together. But if you just go on PubMed and look at some of their papers, I think they've done a really good job with the hip. So, a couple good researchers to look into if that is a topic of interest.
Yeah, we're actually going over a bunch of papers, and those authors are definitely included. So I highly recommend them. My introduction to gluteal tendinopathy was all through Allison Grimaldi. She has a lot of good podcasts out there too. So we'll talk about some of their papers, and they're very, very good. We'll obviously keep the references in the show notes. You guys can check that out. So if you ever want to see where we're drawing these studies inclusions from, they'll be right there. So you just mentioned this, but we're going to talk about education and load management. And this is coming directly from Allison Grimaldi. This was a very recent study. I think this is 2025 or 2024. It's entitled Gluteal Tendinopathy Masterclass, Refuting Myths, and engaging with the evidence, right? And she has some really good key points about load management. And in some subsequent studies, this made up a substantial portion of what the patients were told to do, right? And what we'll find in a minute is that patient education may be the most important thing you do as a physical therapist. So this becomes really important. So key point, we talked about this in the last lesson, what PTs need to know about gluteal tendinopathy. Going to adduction increases compressive forces on the glute medius. So one of the things the patients were told, especially early on when they were rehabbing from gluteal tendinopathy, is to spend less time in adducted seated positions. So if you're sitting down and crossing your legs, so that could be with your leg over your knee or just crossing your ankles with your feet really close to each other, that's going to cause increased compressive forces on the gluteal tendons. So just consider keeping some space between the knees when you're sitting. We also want to spend less time in adducted standing positions. So essentially, if you're standing and you sink into that hip, right, which is a position of comfort for a lot of folks. So this is hilarious, but I remember I had a patient recently and she was dealing with gluteal tendinopathy. And we were just kind of summarizing at the end of her session. And I was just saying, just make sure you spend some time out of that, like kind of sunken into your hip position. And she was like in that position as we were speaking. It's just really tough for some patients to break those habits. So they'll be sitting down, cross their legs without even thinking about it. And then we spend like 20, 30, 40 minutes in that position and they uncross their legs. You're like, oh, my hip is killing me. So it's important they just put like those things together and don't spend so much time in those positions. I think you had mentioned like if you have a baby on your hip out to the side, that's also going to increase those compressive forces on the hip. So we just want to think about those positions throughout the course of the day and make sure we're not spending too much time there, right? So if you are standing, potentially not leaning into that hip or just having a wider stance. So if you're going to be standing for a period of time, your hip is starting to hurt, you just widen that base of support out a little bit. Sometimes that eliminates your hip pain and feels quite a bit better, right? And the last one is spending less time in adducted sleeping positions or lying directly on that side. So if you're laying directly on the hip, you might want to think about flipping to the other side or putting a pillow between your legs, which will abduct the hip and decrease some of the stress there. The other position that Allison Grimaldi recommends is lying on your belly with one leg up. And essentially the leg that's up is the side that doesn't hurt. So if you have one leg up and you're kind of halfway onto your side, you're not lying directly on the gluteal tendon. But if you're a stomach sleeper, that's still pretty comfortable, right? Or a side sleeper that's also still pretty comfortable. So the problem that occurs with a lot of folks is that they may try to sleep in a given position, like on their back, and they just wake up directly on their side, right? So for these folks, sometimes they have to be given a position that's similar to the position of comfort that doesn't load the gluteal tendon, because when they fall asleep, they're just going to wake up right in that spot that hurts again, right? Or they won't be able to get comfortable and fall asleep because you're in a different position. So if you have ever tried to go from being a side sleeper to like a back sleeper, you'll know what I'm talking about. It's like it's impossible to fall asleep, right? So it takes some time and training. So if you can give your patients a few options, usually that's helpful, right? So from a load management perspective, when walking, you can trial utilizing a wider stance. This can also be particularly helpful for runners. So if you have like a crossover gait, or you're constantly landing with a very narrow stance, if you widen that up a little bit, that can reduce some of the strain on the gluteal tendon. You can also trial landing softer, or you can trial standing taller when you're taking a step. The thought being is if you stand really tall, every time you take a stride and you're not sinking down into hip drop, they reduce some of the compressive strain on that hip, right? From a stair perspective, you can try to keep a more level pelvis when you're going up and down stairs. This is also going to apply when you're doing exercises. You can also try widening your stance. So essentially, when you're going up the stairs, you're kind of waddling up with a really wide stance. Now, this sounds hilarious, but when I had bilateral gluteal tendinopathy myself, it hurt a lot to go up the stairs, and I would go up with a really wide stance, and it actually helped a lot. The other thing that can be helpful is to use the handrail on the contralateral side. So if your left hip hurts, using the handrail on the right side, that'll reduce some of the tensile strain on that hip as you go up the stairs. They also recommend reducing stretching. So any stretching into adduction or IT band stretching. So the thought is like, oh man, my IT band is really tight. Need to stretch it. It's killing my hip. That's going to help me. It might potentially aggravate the area, right? So I've heard some people, I think that early on in rehab, it's probably important to do this, but I'd also, put some, I would probably refute this a little bit towards the end stages of rehab, just in the sense that we probably have to strain this and add some compressive loads later on in rehab. At least in these studies, patients were not told to go back into a stretch position eventually. But if you have a higher level athlete that needs to go back into adduction eventually, I would say that potentially doing some IT band stretches might be a positive thing, right? And then lastly, during rehab, you want to be mindful of your pelvic positions. And in these randomized controlled trials, they did that. So essentially, when you're doing something like a step up, making sure you're not going to a lot of hip drop while you're doing that step up, trying to maintain a neutral hip position, minimizing hip adduction. And this is performed during step ups, lunges, etc., as well as things like running. So for higher level athletes, we probably want to stay away from the adductive position initially, and over the course of time, we maybe bring that back, right? So, any thoughts on that before we go into the next study, Kevin?
Yeah, I know we talked about that in a little bit on the previous episode, but I think that stuff's so important of educating the patient on what positions might be provocative just throughout daily life, and then how offer them suggestions of how they can modify those just so they're not, picking the scab or however you want to think about it to keep things kind of that um, low level of irritation. And then I'm totally with you on the rehab program. Obviously makes sense to avoid some of the compressive things early on. But I think getting back to those positions, like you said, for depending on what the patient wants to get back to, will be important. And that's kind of a principle that we use for all types of rehab, right? Like for the person who has flexion intolerant low back pain, maybe we avoid that type of thing early on, but we try to get back to that by the end of rehab. I think the same principle would apply here, right? So getting into like a crossover box step up or like a curtsy lunge or something like that in the terminal phases of rehab would make sense. But obviously early on, we're trying to reduce those types of positions to get a reduction in symptoms. So I think that seems like a really good paper that hit on a bunch of those things. But I'm with you. That's something I definitely want to add in towards the end.
Yeah, so I think it's because we're in a sports setting, and even like the older patients we see are usually very fit and athletic, so they typically want to get back to activities where you have to adduct a bit. So We're just a little more conscious of that, I think. But yeah, in these studies, they didn't include that at end range or end stage rehab. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you can get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning. All right. Now, this study is kind of sad and just kind of challenges the way I tend to think about rehab for these folks. And we can discuss potentially why. But this study was looking at exercise versus sham exercise. This was the GLOBE trial. The name of the study was Gluteal Loading versus Sham Exercises to Improve Pain Dysfunction in Postmenopausal Women with Greater Trochanteric Pain Syndrome, a randomized control trial. Now, we should probably have more studies like this. I'm not even sure why we decided to make this study in gluteal tendinopathy versus rotator cuff related pain or versus like Achilles tendinopathy or other tendon disorders, right? We probably need to see more studies like this from a surgical standpoint, more sham surgeries, right? That type of deal. But basically they were trying to figure out if sham exercise was as effective as exercise where directly loading the tendon, right? And the other thing that was pretty funny about this is that one of the authors here is Jill Cook, who's like the load it specialist that always criticizes PTs for not loading enough. And that's the reason why we don't have success as physical therapists. So what are some of the key points from this article? They took postmenopausal women with gluteal tendinopathy. Now, keep in mind, postmenopausal women, the average age was 52 to 75, right? So older women, we're not seeing a bunch of young athletes. There's 94 women included in the study. So group number one was an exercise protocol. They used the GLOBE protocol, which essentially has 4 phases, pretty similar to the last slide we talked about, where you have progressively more challenging exercises. Then group 2 was a sham exercise. Essentially, they tried to mirror the same phases, but with sham exercises that didn't directly load the gluteal muscles. And they did this through mostly seated exercises. So think about exercises like calf raises or like knee extensions, right? They also did some standing exercise like standing side bends, which didn't really target the glutes very much. But the idea was that they were kind of progressive in nature and they had phases. So they had a fairly robust sham exercise prescription protocol, which is just hilarious, right? But I think they did a pretty good job of shamming it so like the patients wouldn't know if they were loading the area versus not, right? Because obviously it's tough to sham exercise versus not. And then the other thing that I think is really important to understand is that both groups received education, similar education we just talked about. Now, I think this is important that we talk about because we know that in other areas of the body, so for the rotator cuff, I think is a really good example. We have research to show that the education might be the most important thing that we give to people, because if you exercise and give exercise, or excuse me, if you educate and give exercise, in some studies you have the same outcome as if you just educate, right? And some of those studies aren't fair because the education consists of exercises to do, right? But some of those studies it doesn't, and it might be the exercise that gives us the majority of our benefit. We don't really know that. I would love to see this study performed where they didn't have an education group and see if the loading actually was important, right? So tough to know. But anyway, let's get to the results before we talk about that. So what were the results? Adding a targeted gluteal exercise program to comprehensive education did not improve average outcomes beyond education plus sham exercise. However, a subset of responders benefited more from the GLOW program, suggesting potential subgroups of greater trochanteric pain syndrome or gluteal tendinopathy patients who may respond better to gluteal loading rehabilitation, right? So kind of sad because adding load directly to the tendon didn't seem to change the outcome compared to just regular movement that didn't target the gluteal tendon, right? And one of the thoughts being is that maybe exercise alone may produce meaningful improvements in gluteal tendinopathy, right? Maybe the education is really the biggest, most important thing. The other thing that popped into my mind is that, if you look at, let's say, non-specific low back pain, or you look at rotator cuff related pain, you can stretch, you can do Pilates, you can walk, you can do all sorts of active things, and it seems to help, right? It doesn't seem to really matter what you throw at these patients. Both of these patient populations were given exercise. It's just that one was specific to the hip. And the sham exercise group was actually fairly robust. So I kind of wonder if maybe we just have more non-specific effects for this age group, right? My other thought is that they're not particularly athletic. If you look at, like, let's say patellofemoral pain, it seems like if we're more specific with quad exercises and hip exercises, it's better than maybe hip exercises alone. I don't know. What's your take home from this, Kevin? What are your thoughts on this?
Yeah, and I'm not sure if you were going to touch on this or if you came across this. I just was pulling up a study as you were saying that. One study also with Allison Grimaldi, Paul Hodges, and Vincenzio was titled "Psychological Factors, Not Strength Deficits, Are Associated with Severity of Gluteal Tendinopathy." And I didn't dive into that study. I do remember hearing about it, and I remember hearing about the study you were just talking about. And you wonder a little bit, like, without getting into that study too much, it does seem like depression and anxiety and other psychosocial factors play a role in gluteal tendinopathy and pain severity with it. So you almost wonder if just doing something is having some sort of effect on the patient's pain in ways we don't understand. So I think all pain complaints and patient complaints are multifactorial, and there's a lot that goes into it. And gluteal tendinopathy seems to be in that category, like low back pain and neck pain, and maybe some other things that they're not just mechanical. And I think you corrected me on this a little bit last podcast when I was on the gluteal tendinopathy, when we were talking about uh, how loading is going to remodel the tendon and help people get better. Well, that's just one way it could potentially get better. And I think in our patient population, that's a way that makes sense to them. But I also think that's important to keep in mind, and maybe one mechanism of why these patients with seemingly very low level exercises did get a little better. So I think interesting stuff. And there's a lot to it that we maybe don't understand.
Yeah, I agree with you. And that is one of the things that the authors mentioned, is that there's maybe a psychosocial component to it, and we're potentially intervening on this. I think the question becomes, how should our interventions change, right? It's like, if we think the majority of this patient's problems are coming from psychosocial, origin, how do we alter our exercise prescription? Does it not matter what we do from an exercise standpoint? Maybe we're just trying to get them to walk. Maybe we're just trying to get them to do some sort of activity they like. Maybe it's like, okay, you have gluteal tendinopathy, but you love Pilates. Let's just get you on some Pilates, right? Let's get the positive benefits that we're getting from exercise, however we can get them. And maybe like low back pain, because this is the way I've drifted with my treatments for low back pain, is that we know a variety of things are beneficial. Let's just figure out what you like to do and you're more likely to do, and let's do those, right? I don't need to get your transverse abdominis firing appropriately, right? We know that that's not the only way to help someone, although that certainly can help. Let's figure out the best way to get some patient buy-in and get them moving. I think that we just don't have the research yet for these folks, right? My bias, and this is always my bias, and I don't know that we've substantiated this with much literature at this point, but when you get a more athletic population, more sporting population, my personal thought is the biomechanical stuff probably matters more. And when you get a more sedentary population that doesn't challenge their body as much, I would assume the biomechanical portion is less important, right? But that's my own bias, my own belief. When I have an athlete that has a hamstring strain injury, probably need to get that hamstring strong enough to handle the force of sport. But when I have someone who has gluteal tendinopathy, maybe it doesn't matter as much. But I think you could also argue that most of that change could just come from the patient education. So I think that's why if we didn't have a patient education group, would we have seen a difference, right? So maybe in my mind, if you can get that tendon to be more robust, it can handle more behavior that loads it, right? But if you educate that patient not to strain the tendon, it's not going to matter as much because that tendon might just get better because you're not loading it, right? But who knows? Maybe that's false. Maybe my way of thinking is not correct there. I think we probably just need more research over the course of time. But those are my thoughts or opinions as to why we see that. And I think we probably need to be, I think what some people are going to say is that exercise doesn't matter. Like, look at that study, doesn't matter. And I think that we probably don't have that information yet. We probably need to dig into this a little bit more, but I think people are going to take a look at those results and probably come to that conclusion, which is probably not entirely fair. Maybe it is, but we just don't know it yet. I don't know, in my opinion.
Yeah, and they were doing something, and like they said, it was non-specific for the glutes, but they were doing something. And compared to the wait and see, which we know really isn't that effective, exercise is probably the best way to go. But how specific it needs to be might just depend, like you said, on the population you see. And I like to think at the end of the day too, like what's the patient's goal? Is it just to get out of pain? Because that's a little different than if it's a runner trying to get back to sport. Then, like you said, we want their gluteal tendon to be able to handle the demands of the sport. So we should probably load it. And then also, like, I think we're in the business of promoting health, and we want to help these patients get into loading programs and conditioning programs. But if they're just trying to get out of pain and they're very sedentary, we could kind of meet them where they're at, and they might still get better too. So
yeah, that's a really good point. I mean, this is my whole brand, so I probably should have said that first. But if you can help someone get out of pain while you're getting them stronger, making them live longer, which is crazy. Like if you can get someone in a regular exercise program, you can actually add years to their life, which is nutso to even think, improve their health in a very substantial way. Why would you not try to do that? Like, I'm not going to give someone an intervention where they're doing like a heel tap or toe tap while they're sitting, right? And like a standing side bend, when I'm going to have them squat and lunge and get so much positive benefit from a loading perspective, right? And my other thought is that, at least from like a therapeutic alliance and a patient buying perspective, if I can sell something to them that makes sense, I think they're probably more apt to do the exercises as opposed to saying, we're going to do these side bends because the exercise doesn't matter what it is what causes the change. I think you get some analytical thinkers out there that might just not believe you and go somewhere else. Whereas if you're in a study, you're like, all right, well, I guess I got to go through this, right? At the end of the day, it might not make a difference, but at least where we're we're basically trying to meet people where they are, and we're trying to build that buy-in and therapeutic alliance. And I think for a lot of athletic folks, like, yeah, they want to hear like, oh, my glute tendon's not handling this, and I need to get it stronger so I can handle the things I want to do. So I would still be biased towards loading. But I think what this shows us is it's challenging our biases, and maybe we don't need to be that specific. So if it's someone, like, I get them all the time. I had a patient the other day that, like, she hates strength training, just wants to do yoga. And I'm like, dang, like, I wish she liked strength training. It'd be a lot easier, but can I give her yoga and get her better? Maybe this is something that really helps her out. So I just want to make sure that I'm giving her the best possible treatment that she'll actually do. You know, if I tell her to go do deadlifts, like, that's the last thing in the world she wants to do. She hates deadlifts, right? Yeah. So if I can tell her just do Pilates and she loves it, maybe that's the way to go. I don't know. Okay, moving on to injections. So we have a couple different types of injections. Do these help with gluteal tendinopathy? So the first and the most common is going to be a corticosteroid injection. And I'm taking this information from a study that's recent, 2025, the efficacy of gluteal tendinopathy treatments, a systematic review. So they looked at a lot of different studies just to see the effect of different types of treatments. So from a corticosteroid standpoint, what they were showing is that corticosteroids are not superior to exercise and education. We already know this. Corticosteroids tend to have a small effect on pain in the short term, not always superior to exercise and education. And there's a non and a negligible effect on pain in the medium to long term, right? This kind of makes sense too with what a corticosteroid does. It tends to reduce inflammation early on, and it tends to weaken tissues long term. So I tend not to recommend corticosteroids unless you have someone who's kind of recalcitrant, that's not getting any benefit from the exercise, then maybe we'll think about performing a corticosteroid. So how about PRP injections? Because PRP injections are kind of the new kid on the block. We have a bunch of local physicians that like them. I've recommended a lot of people consider doing PRP injections just because PRP injections have shown pretty good effect, in my opinion. And they don't have that negative downside of corticosteroids of potentially weakening tissues, right? So what does the research show? So if you take PRP and combine it with exercise, it tends to have a superior outcome compared to cortisone. And this is based on a modified hip Harris score at the 12-week mark, right? Now, take this with a grain of salt because you're combining PRP with exercise. And oftentimes, that's how you do it. I tell folks PRP is almost like a mini surgery. Oftentimes, you want to combine PRP with exercise because we know there is a synergistic effect. If you take a rodent and you give it a PRP injection into a tendon injury, and you also inject it with Botox so that the muscle can't fire, you don't get the beneficial effect of PRP. But if you encourage that mouse to exercise with the PRP, you get the beneficial effect. So there seems to be a synergistic effect. However, we probably need more research that compares PRP and exercise versus PRP alone. But what it does mean to me is that if you have a patient that doesn't get the beneficial effect of exercise, maybe we give them PRP plus exercise. And I think this is what you generally see in a PT setting. This is generally what we do. We have a patient that's not seeing benefit from exercise. We get them to a doctor, they got PRP, and they come back in and they do PRP with the exercise. And at least anecdotally, we see positive benefits from that standpoint, right? And what we tend to see is if you compare PRP against cortisone injections, you see a superior effect of the PRP injection over the cortisone, which is maintained at the 2-year mark. And that's with pain and function, right? And that was in a study that did not combine PRP with exercise. So it seems like if you look at a cortisone injection versus a PRP injection, and you don't have exercise in the mix for either of the groups, the PRP is more beneficial in that long term. So at least in my mind, if someone's not getting better whatsoever, I'd rather them do a PRP injection over a corticosteroid. Problem is that PRP is not covered by insurance. So I'm not against people trying a corticosteroid if they have no benefit from exercise. And I typically do see this relatively common. But I think it's important just to educate the patient that, you know, exercise is usually going to be as good, if not better. So if you have the choice of doing physical therapy or corticosteroid, definitely go the physical therapy route. But if things are not getting better, maybe the corticosteroid can be a benefit. However, I'd rather you try a PRP if you have the money to do that, right? I just wish that PRP was covered by insurance. It seems so silly to me that it's not, especially given that PRP is not that much more expensive than a corticosteroid injection if you look at the health costs of these treatments. So any thoughts before we move on? Because I know that we have a pretty good relationship with some PRP docs. What are your thoughts there, Kevin?
Yeah, I agree with you. I wish it was covered, and I think that when one of the PRP doctors we work with came and talked to us as a staff, it was very helpful to hear his perspective and his team's perspective. And I think that as PTs, we need to be on the lookout for more research coming out with PRP, because what he was saying is that a lot of clinics, a lot of doctors, there's not a standardized um, way to do the PRP injection. And for, I'm going to get the terminology wrong, but for how many platelets they try to extract, there's an amount that is probably helpful. And I think a lot of it is anecdotal right now. And as you know, he's very into the research, and I think that's why we think his outcomes are a little bit better than some other docs. But I think you want to go to a doc who's definitely looking at the research, and if someone's dissuading you from doing PRP, talking to someone who really knows the research, because it's like, I've told patients since hearing that from Eric, is that, I think the poison's in the dose, or what's going to get you better is in the dose. And if you're just, to say PRP works or doesn't work, it's like saying exercise works or doesn't work. It totally depends on the sets and the reps and the intensity in terms of exercise for whatever outcome you want. And there's a lot of nuance there with PRP, and it's definitely out of my scope. I don't know all of the details of that, but I do know a doctor in the area that we trust. And I think that's really important, is that they're up to date on the specific parameters of the PRP to make sure that the patient's going to get the best outcome. So I think it takes a little research on the PT's end to find someone you trust in the area. But I'm definitely with you on the steroid injection. I get nervous with steroid injections into tendons. It just doesn't seem like the best idea in terms of the risk reward. And you might have a decrease in pain, but what are we doing to the structure of the tendon? And we know with PRP, we can get healthier tendons with the injection. So I think it's something to be on the lookout for as PTs, as more evidence comes out, and trying to find doctors who are up to date on the research for PRP is, I think, going to be really important, because it seems like more and more of it's coming down the pipeline. So we should get familiar with it now.
Yeah, and it's funny. I probably should have mentioned this, but as you were talking, I just looked up the study because I know we covered this study. I believe it was either in the meniscus section or the knee osteoarthritis, but there's a study. It's very recent. It's 2025. Berrigan. A greater platelet dose may yield better clinical outcomes for PRP in treatment of knee osteoarthritis, systematic review. And what they showed is that as the dosage goes up, there's a very clear improvement in pain and function, so much so that the highest dose reduces the progression of osteoarthritis over the course of time. And I know we talked about this before, but you have to be careful where you're sending your patients for PRP, because when Dr. Eric Laska came in and gave his in-service for us, he was basically showing us that most clinics don't purchase the equipment because it's expensive to measure the amount of platelets that they're drawing. And what they do at Eric's clinic is that they draw your blood, they spin it in a centrifuge, and they measure the amount of platelets. And if it's not enough, they end up having to draw more blood and spin it more until you get the right dosage. And most places are not doing this because it's a quick buck. What's funny is over the past 5 years, we have our favorite docs that we like for PRP injections. And essentially now a patient will go to a surgeon that I've been working with for 10 years, 15 years, right? And essentially I'll send the patient to a different doctor, right, for PRP, but they may have a follow-up with their surgeon. The surgeon says, oh, we could do PRP. It's like, whoa, when did you start doing PRP? But I think it's just it's quick, it's easy. And I think oftentimes patients are not getting the correct dosages, even though they're paying quite a bit of money for it. And I think oftentimes what you're seeing is patients will go to a clinic and they'll get a PRP injection, and essentially the person drawing and administering the PRP will say oh, we hit a bunch of different areas. We inject a little here, a little here, a little there. And the patient's like, oh, wow, that's great value. When meanwhile, they're getting a suboptimal dosage in multiple places is probably going to do nothing, right? So I think it comes down to, and we say this all the time, you have to have good doctors that understand the science. You have to protect your patients because the patient has no idea, right? And they're like, oh, this is convenient. This doctor can do PRP. Why wouldn't I just go to the doctor I'm already going to? It's like, well, because they're going to be wasting your money. Like, do you want to spend over $1,000 on this, right? So really good point that I completely forgot, Kevin.
Hey, pardon the interruption, but if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So, what are these problems? Number one, failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay imbalance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free. And better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program.
Okay. Next one, extracorporeal shockwave therapy. Now, this one, I like talking about it because we have 2 units at our clinic, right? So we have the ability to use this. I think shockwave therapy has been under fire more recently. I actually use it a little less than I used to. I think some of the first studies that came out about shockwave showed great effect, and some of the subsequent research maybe not quite as good, right? So we're looking at the same systematic review as we were just looking at for injections. Included in this review were 4 studies that were high quality. There's no difference in the effect of focused shockwave therapy on pain and function in the short term compared to corticosteroid injection. This is my personal opinion, but we know there is a short-term effect of corticosteroids, right? So if you're trying to get an immediate effect, short-term effect for your patients, right, and exercise is not doing it, maybe the shockwave will, right? Because we know that if you just have a wait and see group, in the short term, there's going to be very little to no effect, right? There is an effect. Some people do get a little bit better. The shockwave might be better than nothing, right? And it's about as good as a corticosteroid, which we know has a good short-term effect. So we know corticosteroids have long-term potentially negative effects, and long-terms no effects. So if you look for that short-term effect, the shockwave does give an effect, right? And I think what we do at Champion usually is we start them off with exercise, but we may hit them with shockwave the first few sessions anyway, right? Does it help over exercise? Not sure. It seems like there is a large effect size of superiority of focused shockwave therapy in the long term, but that's when you combine it with exercise. So it's like, is exercise doing everything, which is the same thing as PRP. It's like we have a bunch of studies looking at PRP. Is PRP plus exercise better than exercise alone? Is shockwave plus exercise better than exercise alone? We just need more studies, right? And I think as more studies come out, it just kind of shows that maybe it is the exercise that's giving it the effect. But I know what we do at Champion right now is we'll kind of hit people with both. Anecdotally, some people really like it, and sometimes they feel really good after shockwave, right? They have a really strong buy-in, or they just feel better afterwards. So it only takes a couple minutes, and we'll hit them with shockwave until I see a bunch of studies that come out that show it has a negative effect or no effect, right? Or the exercise is stronger. I still use it, especially if a patient really believes in it and they really like some of these more passive modalities, right? Trying to build that therapeutic alliance, trying to get buy-in. I see no reason currently to do that unless it makes them feel a lot worse afterwards. I know that we use shockwave at Champion. I think I go back and forth based on the studies that come out. What are your thoughts on this, Kevin?
Yeah, I agree with you. I mean, I think we're very spoiled in the sense that it's not replacing anything else we're doing. We don't charge extra for shockwave. So you administer it based on impacts. And, for most pathologies, we're doing somewhere between 2,000 to 3,000 impacts. And it takes like 3 to 4 minutes. So because of that, there was a period when we got it, I was using it a lot, and then I was using it less. And now I'm using it a little bit more again. I mainly only use it for tendinopathies. That's where it seems like the research is strongest. So I'm with you. I think this is something gluteal tendinopathy is something I would probably try to use it for and just see if the patient has a positive response to it. I think the recommendation is usually to do one treatment session per week for 3 to 5 weeks. And that's Dr. Adam 1040 has written some of that research on shockwave for tendons. And he has a paper that he talks about the frequency and stuff like that. So I'm a fan of it. I'll use it. And again, I think like you had just said, it when combined with exercise, whether that's what's getting our patients better or the exercise, hard to say, or a combination of both. Is that what's helping? But again, for us, it's not like I'm telling a patient to go somewhere and spend money out of pocket for shockwave. We just have it in the clinic, so it's just this. We're just going to do it anyway. And again, it's not an extra cost to them, so it works out really nice. And in that model, I can totally justify using it. If I had to send a patient somewhere and they had to spend money out of pocket, I think I would use it after we tried exercise. If things weren't getting better, like let's try this maybe before a steroid injection, because we know the shockwave isn't going to have a negative effect on your tendon health. So, probably in that order, I would go exercise and education. Maybe let's try shockwave. And then if that's not working, consider PRP or a corticosteroid injection or something like that.
Yeah, I'm cheap too. You know what I mean? Like, at least where we live in the Boston area, people will pay $200 to $300 a session for shockwave therapy, right?
Mm.
And I think a lot of places are making money hand over fist. And I think that's where it gets a little bit suspect. Am I against someone trying shockwave if they've failed conservative treatment? They don't want to do PRP. They don't want to do something that's more invasive. No, I think it's probably a fine thing to do, right? It's just at our clinic, we're so blessed that we don't have to charge people extra. It's like, we're already going to load you. We're going to do a whole bunch of different things. Might as well throw this on top. Is it too much? Might we not have to do it? Maybe, but we're not charging another $300 just to do it. Especially it's like 3 minutes. It's kind of wild, right? But when we tell patients that we have a shockwave and they've done it in the past, right? They're like, wow, it's included with the price of this session. They're like, yeah. I'm like, well, that's crazy, So I think it's a really good positive benefit for some folks and can be beneficial. So I'm the same as you, Kevin. I kind of started off hot with shockwave. I was really excited because I think some of the preliminary research was showing good effect on all sorts of things. And as more research came out, maybe not quite as strong. And now I'm coming back around to it again. It's kind of like I tend to write things off a little too fast and the pendulum swings, but I'm coming back around to some of that stuff too. And I think it can be beneficial for some people because I've also had some people that love it. They're like, oh, I felt awesome after that. Let's keep doing that. And if that's the patient, I'm like, even if it is, we talk about maybe non-specific effects a lot, or we just don't know the reason why some things are helpful. The patient has a really strong belief in it. We know that's going to help them. Like if they like it, and they feel like it's really helping, I'm going to do it. I have patients that love shockwave. They've been getting shockwave consistently for a long period of time, and I think it's wonderful. And it's funny because I will just like go through these periods where I don't shockwave much of anyone, but when they come in, I'm always shockwaving them. It's like they just freaking love it for everything, right? And I'm on board with it because they have such a strong belief. And it's not like I'm only shockwaving them. I'm giving them evidence-based care, but then I give them like a little extra on top that they enjoy. So we're relying on some of these maybe contextual factors. I feel like that's a popular thing to say right now. We're trying to build, therapeutic alliance and work towards, the patient's preference. So I think that if you're using that reasoning, it's entirely reasonable and a good idea to do it as opposed to condemning it and never using it again. So, okay. Moving on to a cool one that I've been really interested in a long time, right? I just like the idea of different types of treatments to help folks with pain besides just exercise. And this one's really interesting. So hormone replacement therapy, right? And we talked about this. So postmenopausal women, they have more pain. And it's not just tendon pain. It's not just gluteal tendinopathy. They have more pain in general. And what's really funny is that if you are in the bodybuilding world, right? And bodybuilders that take anabolic steroids, one of the things that they will do after they finish a cycle is they have a post-cycle therapy, right? And one of the big things they take are aromatase inhibitors, which are going to drop estrogen levels. And this is just like bro science. People will say this all the time. After they take their post-cycle therapies, they start getting tendon pain, right? Their tendons hurt a lot. And the reason why they're taking this is because they want to make sure they don't get like gyno or just like issues that are associated with high estrogen levels and low testosterone because they took anabolic steroids. So they take the post-cycle therapy, and they get tendon pain. And what we're finding here is that postmenopausal women have a lot of tendon pain. And we know that they are producing less estrogen and less progesterone just because they go through menopause, right? So the thought is like, hey, if we give these women some sort of hormone replacement therapy that consists of like estrogen and progesterone, we know that these compounds are beneficial for tendon health. Does that help to reduce pain? And this is a really cool study because I knew about this study and it had been completed for years. And I was dealing with a couple of different patients that had gluteal tendinopathy, right? And I was like, man, I'm really excited to see what happens with this study to see if this might be like an option. I actually had one patient that just went on hormone replacement therapy prior to this study being published just to try it herself. What's cool is that she thinks it helped her, right? But essentially the study was published in 2022, American Journal of Sports Medicine. So good journal there, called Does Menopausal Hormone Therapy, Exercise, or Both Improve Pain and Function in Postmenopausal Women with Greater Trochanteric Pain Syndrome? A 2x2 factorial randomized clinical trial. And this had Jill Cook, as well as Charlotte Gannerton, who I think was a global hip trial. And maybe Rachel Mary Cohen was also on that paper too, but I'm kind of getting confused with different papers at this point, right? So they had a menopausal hormonal therapy group, which received estradiol and progesterone cream. They had a placebo cream group, which was great. And they also had these patients either performing exercise, which is the GLOBE protocol, which is essentially the same protocol they used in the prior study we talked about, and a sham exercise group, which used the same GLOBE sham exercise protocol, which was 4-stage. I thought that was interesting. And it's funny now, is I wonder if like any study moving forward now has to include an exercise and a sham exercise group, just to control these variables. And I think the other piece that was interesting, it was the same as the sham exercise study we looked at before, is that all groups received education about avoiding gluteal tendon compression and load management throughout the 12-week intervention, right? So they also, every one of these groups received education, right? Which we know might be the most important thing. So I think that what they're trying to do is control these variables, which they controlled for in the past, which these studies might get ridiculous in the future because it's like you have to control for hormonal level, you have to control for the exercise type they use, you have to sham everything. Like these studies are going to get crazy, But anyway, very interesting. So first thing, all participant groups improved over the course of time. And this was at 12 weeks as well as 52 weeks. Second thing, which is very interesting, which we already knew, is that there's no difference among exercise groups. So there was improvement in the sham group and there's improvement in the exercise group, whether or not they had the hormone replacement therapy or the sham hormone replacement therapy, right? But the hormone replacement therapy groups had significantly better VISA-G outcome scores as compared with placebo at all time points, particularly when BMI was less than 25. So if you had your BMI less than 25, you had a better outcome. And this was with exercise and education. So what this study showed is that the application of hormone replacement therapy was beneficial for these folks, right? And I guess what I had put down at the bottom here was, does exercise even matter? Is exercise the most important thing? Maybe the most important thing is patient education and the application of hormones, right? Because it seemed like the sham exercise group did just as well. But the other piece is like, I would love to see a group that did nothing, right? Because we know we're probably getting some sort of effect from the placebo exercises. You know, if we have people that just take hormone replacement therapy and they're educated and they're not given any exercise whatsoever, will they have the same effect, right? Or can we be more general with our exercise prescription? Like, hey, you need to walk 3 days a week, right? Or you need to do yoga, or you need to do something. I'm just really curious, but at least what this study added to my arsenal is that, hey, this is something that can help you. Maybe talk to a physician who can prescribe hormone replacement therapy. It's that there are contraindications of taking hormones, right? Particularly with women who have a history of things like breast cancer, right? This becomes a big issue. So it's important that, patients are aware of this and they go to a doctor who knows this research and they're just aware of the side effects of prescribing hormone replacement therapy. What are your thoughts on this paper, Kevin?
Yeah, I think you're hitting on an important point that it's like, how can we educate patients about things other than just exercise and mechanical positions to avoid? And this is something I've heard talked about a little bit from some PTs I follow. When a postmenopausal woman is having chronic different types of tendon pain, it could be gluteal tendinopathy, it could be hamstring tendinopathy, any type of tendinopathy. There must be like some type of hormonal metabolic component, and it does seem like it can improve pain and function. And again, it's kind of out of my scope, the full range of benefits that hormone replacement therapy has for postmenopausal women, but I think the more research comes out, there are a lot of positive benefits for a lot of things other than just tendon health. Whether that's like energy standpoint or how they feel in the gym with strength and conditioning and stuff like that. So I think it's definitely something to explore and a conversation a patient could have with their PCP, but it might be something that they just totally are unaware of, that, they think it's I don't know, a fringe thing or something that they're just unsure about how it would impact their musculoskeletal health. So yeah, this paper I think is interesting, and it's definitely things I think we'll see more of in the future as that therapy probably gets better and better and more specific to the patient over time. Um, Something that could help these older women just feel better throughout life and maybe help with their pain problems. So definitely
Yeah.
something we should know about as PTs.
Yeah. The other thing I will say is that I've had several patients where they figure it out on their own and they just get mad. You're like, why did my doctor never tell me about this?
Hmm.
And the research is newer. I think that's one of the reasons why. Like, we have one paper on gluteal tendinopathy that had like a small sample size. Most physicians are not going to look at this paper and be like, yup, gold standard. Everyone gets hormone replacement therapy. I think that's, we operate in a different world where you have like small populations, small sample sizes. Like, we don't really have these enormous study with thousands of people. And I think oftentimes physicians are a little bit more skeptical of these newer, smaller studies, right? And they want to see more published data come out before they accept things. But I think the flip side of that is that there's a potential benefit that a patient may have, they just don't get, because it's a small sample, or it's potentially published in a journal that, physicians don't read, so on and so forth, right? So this is kind of a physical therapy journal. They're not going to necessarily read these types of journals. So again, you got to find good physicians you can refer to. We have a couple that are pretty good. I think it's sometimes these physicians are also out of pocket, which is kind of a pain in the butt because they dabble with these fringe treatments that aren't always covered by insurance, right? Whereas you just go to a typical endocrinologist, you're just going to laugh and say, no, we can't do this, right? So you're still going to deal with that a little bit, but I think at the end of the day, it is wise and to just have some doctors that are open to this, at least as a treatment. But also keep in mind that this is one study, right? And we probably need more research. And the side effects are real of hormone replacement therapy for men and women. So we just make sure you have a good doctor that's aware of that. Isn't just willy-nilly patient just trying like an estrogen patch you got, from some lab in China somewhere. You know what I mean? So, because that does happen. You can buy this stuff online now, which is kind of crazy. So, all right. So this next one you may or may not have heard of before. It's called ultrasound guided percutaneous tenotomy, or a TENEX procedure, right? And this one really wasn't on my radar very much. I'd heard it a little bit. And even in that big review paper we were just talking about previously, they didn't even include this, right? But we worked with a couple local physicians, Dr. Latska being the main one, and he loves this. He uses this all the time. And essentially, it is a high frequency energy to debride pathologic tissue under continuous irrigation. So essentially, they have a needle that's going into the tendon, in and out of it, while they are irrigating at the same time. And what I've been told from doctors that do this is that if you have a tendon that has a lot of tendinopathy, or you have a tendon that has calcific tendinopathy, this is kind of like a home run. It can be very, very helpful for patients. And what's interesting is that Dr. Latska specifically, he loves it with gluteal tendinopathy, right? And it's because there's a little bit of research showing it to be effective, but also it tends to be covered by insurance, and PRP is not. So if you have something that's covered by insurance, like, might as well give that a shot, right? So this study was in Orthopedic Journal of Sports Medicine in 2020 called Ultrasound Guided Percutaneous Tenotomy for Gluteal Tendinopathy. Lead author was Baker et al. And they had 26 patients with gluteal tendinopathy, so small sample size. And I think this was a good study because it kind of follows what we typically do as physical therapists. They had 26 patients that failed conservative management. So essentially, they try physical therapy and it's not working, right? Which is probably the right way to go, because you want to try conservative management, less invasive strategies first. And if that's not working, then you try something like this. What were the results? So pain and outcome measures improved in the long-term follow-up at 22 months. So it's almost 2 years out, right? And at final follow-up, I love it when studies do this because I feel like it's very practical. At final follow-up, when asked whether they would have the procedure again, 15 patients replied, yes, definitely. 3 replied, yes, probably. 3 replied, maybe. 1 replied, likely not. And 2 replied, definitely not. So essentially, you kind of see the people that had a really good outcome and the people that really didn't have a good outcome. And what's kind of cool is that it seems like in majority of patients, right, 3/4 of patients, it's kind of a home run. It seemed like it really helped them a lot, and they're very happy they did it. And in some patients, maybe not so much, right? But at least when I see studies like this, I'm much more likely to tell my patients about this. And kind of just like the hormone replacement therapy, there is like a treatment algorithm. It's like, all right, you try conservative therapy, it doesn't work. Here are your options. You can try TENEX, you can try PRP. Now that doesn't work, we can actually do surgery, and surgery actually works really well. And most patients I speak to that have been to physical therapy, they had no idea that there were other treatments available for them, right? What are your thoughts on TENEX? I know you've seen patients with this as well, Kevin.
Yeah, I think that, like you said, I like that it comes after trying conservative care first, and then if it's not helpful, it's an avenue to explore. And like you said, our PRP is not covered by insurance, so this might be a better option for some folks. And it sounds like, you say it's a procedure. It's not like a surgery. It's done very quickly. I don't think they're not put to sleep or anything.
No, it
It's
can
it,
be painful. We'll say that. Like, I've had a
yeah,
lot of patients, because you're not supposed to do ibuprofen prior, and then like they just want to make sure that you have no painkillers on board.
yeah, I
I've had
know.
some patients say it's pretty tough. So
Yeah,
it's invasive from that standpoint. It's not like you're going to get a pulmonary embolism, but it's invasive in the standpoint that can be pretty painful. So
yeah, and I think it rehabs well and it rehabs quickly. It's not like a long post-op protocol. So, and I also like the addition of what you had just added in the study. Like, that's a lot of patients who would definitely do it again. I think that speaks a lot to it. And I think it's one of those things we are seeing more and more. I've definitely had one patient with it with a patellar tendon, and I know our coworker Mike Scaduto has a patient with it right now. And I feel like he just had it a couple weeks ago, and he was out for, I don't know, 10 to 14 days. They wanted him to rest, and now he's he's back and he's starting his return to lifting protocol. So, I think for these cases, it doesn't seem to get better the way we would expect. It's another good thing to keep in mind. And as PTs, we should know about it and kind of keep an eye out in the research to see if more and more papers come out for different types of tendinopathy.
Yeah, I've had a couple now with the gluteal tendon. I think 2 or 3 at this point, and one of them was like she had pain for like year and a half, 2 years, and she just kind of really likes conservative management. Doesn't like the idea of surgery unless really needed. She will go down that pathway, but she had all different types of injections. Nothing was beneficial, and then she tried the TENEX procedure and just rehabbed it and did extremely well with it. So I think she actually tried PRP too. Um, so I think it can be very beneficial, especially for those refractory cases, and I think it's good because, I mean, this wasn't on my radar years ago, but it's something that can really give some relief. And when I have a patient that's come in that's tried a bunch of other things with physical therapy, one of my first thoughts is like, okay, well, what do they do? What was the treatment like? But my secondary thoughts are like, you do realize there's other things you can do besides physical therapy that are beneficial. And they usually have no idea. And oftentimes they've been to multiple doctors and multiple physical therapists. And it's like, well, if you're not getting any relief 3 months or more out, we should probably start thinking about these other things because they can be very helpful. And otherwise, we talked about how debilitating gluteal tendinopathy can be, right? People are dealing with that and they can't exercise, right? They're getting more and more sedentary. They're not going to work. Like, heck, try some TENEX. You know what I mean? That can really be helpful. So I think it's useful. Okay. And then kind of the last ditch effort is surgery. And I'll tell you what, this is not a common surgery that I see very much at all. I know the surgery exists, right? And what I tell patients, and they usually don't have to get to this point, is that this is something that can be beneficial for you if you don't see progress with conservative management or injections or TENEX. You can get surgery for this, right? And this was a good study. It's a systematic review. I think it's recent, 2021. Yeah. So it's titled Both Open and Endoscopic Gluteal Tendon Repairs Lead to Functional Improvements with Similar Failure Rates. A systematic review. Lead author was Longstaff. It was a systematic review of 22 different studies, 604 hips. So this is a surgery that's done a decent amount. Our local surgeon we like a lot, Dr. Wirtz, he does this procedure. He just doesn't do it that commonly, right? And essentially 91% of the hips included for females, average age of 62. So it kind of reminds me of like rotator cuff issues. They tend to get worse over the course of time. Obviously, for gluteal tendinopathy, it's going to be more common in women, right? So the majority of patients you're going to see are a little older, a little more sedentary. And I think you probably need to just keep that in mind when you're recommending patients get the surgery, because if you say you have like a 30-year-old that has a tear of the gluteal tendon, you can't always like put your hat on like, yeah, it's going to go really well. Like we don't really know that. And essentially the majority of tears included were partial thickness tears. We talked about this before. You can have a partial thickness tear of your gluteal tendon. You can have a full thickness tear. You can also have a small, medium, or large tear. They can be very similar to the rotator cuff, right? In this study, the glute medius tendon was involved in all cases, but in 46%, the glute minimus tendon was involved. You can repair that as well, right? The other thing is that this mean symptom duration was 3 years. So these folks have had pain for years and years. It wasn't like they just had a acute tear and they're getting repair. These are mostly chronic, right? And these were repaired either open. Essentially, they take a scalpel and they take a big cut right by the glute medius tendon, and they do the surgery open so they can see and visualize everything, which potentially is better for a bigger tear so they can see what's going on. Or they do it endoscopically, arthroscopy, which is how most surgeries are performed, right? And basically, they have to repair the tendon, and they can do it via suture anchors. So essentially, they suture through the tendon, and then they basically screw that into the bone. Or they have transosseous fixation, so they have like a bone tunnel, and they suture through the tendon, then through the tunnel, and fixate it down, which might be a stronger fixation, right? And then they have a rehabilitation protocol afterwards. So this is a surgery just like a rotator cuff repair, fairly in-depth rehab protocol. It's not like you're getting this on Tuesday and walking the week following, right? You've got like a 6 to 9 month rehab after this. It's a fairly tough rehab with a non-weight bearing, so on, so forth period afterwards.
So what were the outcomes of this surgery overall? So I will say good. It actually surprised me how good. So there's an average increase of 30 points on the modified Harris hip score. So the modified hip Harris score goes up to 91 points. So you're seeing on average a 30-point increase. So you have someone that was pretty debilitated before, like around a 50, they get up to an 80. It's pretty dang good, right? So from a pain perspective, VAS score 0 to 10, there's an average 5-point decrease on average in pain, right? So if you're always sitting around a 5 out of 10, it took you down to 0. If you're always sitting around a 6 out of 10, it takes you around to a 1. I think on average, that's pretty good. I would also assume that people that had really bad pain, they probably had a greater reduction in pain, because if you had on average a 3 out of 10 pain, you can't go below a 0, right? You're not like, now I'm a -2. That doesn't make any sense, right? So I think a 5-point is a very strong reduction in pain. Patient satisfaction was an 8.5 out of 10, which I think is great. And when asked, 94% of patients would repeat the procedure, right? So I think this is really cool, because we have, like, some patients have this recalcitrant lateral hip pain. Nothing is working, but they just don't want to do surgery. It's kind of like, just get the freaking surgery, because it's probably going to do well, right? There is, some light at the end of the tunnel and some hope. And I think as physical therapists, we're constantly trying to treat everything conservatively. But if you have something that's more invasive, like a surgery, yes, it's going to take a long time to recover from, but you can have a really positive improvement at the end of it. I think you probably should recommend patients potentially try that, right? I did try to see if there's any return to sport data on this. There's none. And the reason being is that, like, the average age is like 62 years old. Most of these folks are not returning to sport, although, like, you can make the argument that a lot of these folks probably want to return back to golf. They probably want to return back to tennis, right? Folks at this age are still pretty active, but they just didn't report on this in any of the studies. But they did say that most folks were returning to their activities somewhere between 6 and 12 months. So it takes a while to get back to things, right? But you can get back to your activities, which, I think is a good thing. Any thoughts on this, Kevin?
Yeah, that's not a surgery that I've seen, but it is good to know it's there as an option, and that there are very good outcomes. 94% would do it again. I think that's amazing. So I think with any surgery, there will be a small percentage that doesn't have a great outcome, but that's pretty reassuring. And, if everything else that you talked about from a rehab treatment standpoint isn't helping, it's good to know a doctor who does that surgery and, can give these patients relief. And then it's also just, you could frame it for the patient too. Like, you've had this pain for probably at this point years, easy to say, but like, what's another 6 to 9 months in the grand scheme if you're going to end up getting a better outcome long term? So there is a time and place for surgery, and we can't be afraid as physical therapists to accept that non-op care or conservative care isn't working, and to refer out when needed.
Yeah, especially if you can't work, you have so much disability, you can't do the things you love, right? And maybe that is the way to go. We got to get Dr. Wirtz on here at some point to talk about FAI and labor repair, but also some of these other surgeries he does. I'd love to pick his brain a bit. If you guys want to earn some CEUs for watching this content, if you're a physical therapist, physical therapy assistant, or athletic trainer, highly recommend you subscribe to Insiders Academy, which is our premium subscription membership, where you can earn CEUs for watching this exact content, as well as getting some additional insights. So essentially what we do is we take all this information, put it into a master course. We also include our protocols and case studies to exactly how we rehab these. It's $1 for a week trial and $25 a month afterwards. I'll put a link in the description. You guys can check that out. And if you want to keep going with your learning, having gluteal tendinopathy oftentimes is going to coexist with femoral acetabular impingement syndrome. So sometimes you get a patient that has both and need to know how to treat both. And we have a video for you. We'll put that right above Kevin's head, where we go over what physical therapists need to know about femoral acetabular impingement syndrome and how to treat it. So go ahead and click on that link, and we'll see you there.